Good afternoon, everyone. Can folks hear me?
Yep.
Great. Thanks for joining office hours, everybody. Happy March. Can folks see the slide deck okay?
Yep.
Great. All right. So if anybody, as usual, has any questions along the way, please ask or comments. We have the chat function as well, and we'll be recording as always and have this up on our office hours site on the HI website. So with that, we'll get started. So we're going to go through some redesignation items this month from the Children's Redesignation. Talk about the plan of care compliance audit, where we're at in that process. Talk about the Health Home Network audit results to date. The comprehensive assessment required element of billing. That was a note that we sent out to the network not too long ago. Some children's updates, and then just program update and reminders in general. So to our redesignation follow-up, we had a bunch of things that came on our enhanced oversight plan as we were talking last month. So over the next few months, we'll be touching on those items. So these are things that we didn't hit the 90% threshold for as a network. So we're going to touch on those things and tie them back to policy each month as we're going through those items. The first area that we were touching on is along the care transitions policy. So you'll see in these two black bulleted areas were themes that the Department of Health pulled on us that we didn't hit that 90% threshold across network for the files that were pulled. And along the transitions to care policy, the care management follow-up after emergency department discharge within 48 hours, ensuring members with a completed intervention within that 48 hours of ED visit. And then also there was progress notes or any other supporting documentation in the record that showed that that person had been admitted to the emergency room within those 12-month time frame, just showing that there was any support of documentation or notes that alluded to that. So we just want to make sure that we're being consistent with that. In most instances, that was the case, but we didn't quite hit the mark. So we just want to make sure that we're doing that as we're in there in the record. So I don't know if there was any questions or comments around that from anyone. Okay, we'll move on then. Next area is still with care transitions on the care coordination front. There was a comment where we didn't hit the 90% threshold in the network was ensuring visits contain progress notes or other documentation that indicates that the CMA was alerted about the member's ER admission through the RIO within the last 12 months. So just again, progress notes containing indication that the CMA was alerted. So that would be through the RIO. And I know we've had as a network issues with the HCSNE alerts. And we talked about that with DOH when we were going through redesignation. And that continues to be a theme. I know we had sent something out to the network recently. Oh,
Travis, we can't hear you. Can you
Hello?
guys hear me? Oh, there you are.
Can you
Okay.
hear me?
Yes. Now I can.
Where did you lose me?
Right at the end of the last slide,
The
I
last slide,
think. Oh,
okay.
no. We did hear this slide. I'm sorry.
You did hear this slide, okay.
Yes.
Was there any questions or anything anybody had on this particular slide?
Travis, I have a quick question. If we do receive the alert, do we still have to upload the progress note, or is the alert sufficient?
We want to have some relevance that there is a progress notes around the alert. That's what DOH wants to see.
Okay.
That the CMA had notification, that there was, anything around that they're just showing that there was acknowledgement of it. I wouldn't get into like a long-winded story around it, but we get the alerts when they are working. I know there's been an issue with it.
I guess I'm confusing progress notes like with ED progress notes versus our notes. So I'm sorry, I'm not following. So are the notes that the care managers document around acknowledging the ED visit enough, or do we have to upload things from the actual ED? Like discharge
Correct.
summary either.
They're showing, they want to see indication of both.
Okay.
There's acknowledgement from the care manager note that there's acknowledgement that there's been awareness, and they also want to see progress notes from the ED itself.
Okay.
Where-
I think
where
the and/or
possible.
was throwing me
Yes.
off. Thank you.
I'm sorry. If you have both, that's good, or one or the other, if you can only get, but there should be definitely notes from the care manager in the record. Sorry. Good clarification, Jessica. Sorry. Anybody
Travis,
have
you're
anything
saying,
else?
this is Sarah. So you're saying that we should be trying to get something from the ED, because I don't recall that being something that we were asked to do. We're certainly not doing that. We are documenting that an alert came in and what we did, but we have not been getting.
Yeah, that's the same with us, and which we have because we're the primary care. So we have more notes than we'd like, but it's a matter of we're not downloading those and uploading them into NetSmart.
If possible to get them, but definitely have documentation in the notes that you're aware that the person was in the emergency room, had admission. But if you get progress notes, to put those in there is a possibility as well, as what the DOH was saying.
Sounds good. Thank you. I appreciate the detail.
Yep.
Can we print or save a document from HCSCNE? I know before we weren't allowed, but I know we can pull up a progress note from there. Are we able to save that and upload that?
That's a good question. Jessica, I'm going to defer on that one. Jess, is that something that would be, do you think they would have issue with that? Jessica
No,
Robertson?
that's allowable.
Yeah. So that'd be fine then. Good question. Any other questions?
Travis, this is Debbie. Question in regards to when they don't receive the alert, should just they make a note in it, didn't find out until whatever date? Because we are having quite a bit of that.
I would document when you did find out. Yeah,
Okay,
definitely. Yeah. That way you're indicating when you became aware. We have communicated with Department of Health that, as I had said earlier, that, we've been having issues with the HCSCNE alert system. That was one of the things during redesignation we talked about. And we'll be communicating with them in the near future when we meet with them again, that there's been an issue with the NetSmart platform continuously with that as well. So we're being as transparent as we can about this, that it's continuing as an issue. Anything else around this part? Okay. Another one around care transitions. Ensuring a visit contains progress notes or documentation of the record that indicates care manager was involved in the care coordination. Post-discharge, so anything in the last 12 months that had post-discharge care, want to make sure that there's relevance that the care manager was involved in that care coordination of the member's care. Again, we didn't hit the 90% threshold on that, so a good job overall, just that 90% threshold was the issue. Just so we're aware of that. And then care transitions on care coordination, inpatient visits contain progress notes and or any other documentation in the member's record that indicates the CMA was alerted about the member's inpatient admission via the RIO within the last 12 months. So the CMA was alerted about the inpatient admission. And then it was, and again, that 90%, that's a high threshold, as you know. So did a nice job overall, but wasn't quite at the 90%. So just keeping that in mind as we're out there doing our documentation. Any questions on this or comments? And another care coordination on the care transitions policy, ensuring the visits contain progress notes and or other documentation in the member's record that indicates the care manager was involved in the care coordination of their care prior to their discharge. That would be in that last 12 months time frame as well. So prior to the care, prior to their discharge. So we want to make sure we're documenting or showing any documentation around that care or prior to that care of discharge. So then we're
I have
gonna,
a question.
yes,
So when someone's admitted to the ER, sometimes we're not alerted till the next day and they're already discharged. How would we be involved in the discharge prior to their discharge?
I think in those circumstances, you document what you know, right? So I would put in that instance the fact that when you became of the discharge, when you were aware of that, and then try and get any information that you had about their stay, and then just put that information in the record at that point, and then whatever appropriate follow-up thereafter is where you're getting involved at that point. That would be my suggestion there.
Okay.
Any other questions on that? Eligibility and appropriateness, this was of the children's waiver and HCBS policy. This was around the 90% threshold as well. Ensuring the member's record contains documentation to indicate that care manager educated the member and or her parent, legal guardian, or legally authorized rep about the HCBS services that are available to him or her. So again, we did a nice job as a network, but it was that 90% threshold that we didn't quite hit on that education piece and documenting that around HCBS services available. So we just want to make sure that we're out there and keeping that at the forefront. So just more of a reminder of that as we're out there. This one was around health home billing policy, eligibility and appropriateness, just ensuring the member's record contains documentation indicating that the care manager verified Medicaid eligibility each month of enrollment. This is one we went back and forth a little bit on because as a provider, you're attesting to that when you're doing the CBQs or the HMLs for the adults. There's an attestation question that the person receives Medicaid. Another person coming and going. So when you're doing that billing attestation, you're attesting that the person has active Medicaid when you're completing the documentation. So that's our stance as a lead. But there was a 90% threshold hit we took still. So we just want to educate that ensured record contains documentation indicate that the care manager verified Medicaid eligibility each month of enrollment. So we're mentioning it. just note that that was brought up to the group, and just make sure people have Medicaid when you're validating for billing, is what my message would be to the network. Anything, Jessica, you wanted to add outside of that? I think that would be the message.
Yeah, no, nothing to add.
Okay.
Hey Travis, this is Liz at Port Hudson.
Yes.
So our HMLs, we have to mark to say that we did that.
Yes.
And how did we get anything pointed off on that? And then what should we be doing different so that we don't get points taken off for that? I guess I'm not
Well,
really understanding.
I think the only other thing that you would do would be write a case note saying that you validated a person's Medicaid. If you want to write a case note.
Okay, so
validated
you want it
Medicaid.
included in all case note, or at least one case note a month that Medicaid was verified.
I'm not suggesting that. I'm saying if you wanted to take that step, you could do that. It's already on your HML or your CBQ that you're attesting that the person has Medicaid. That's our stance as a lead. DOH, we didn't take that battle up with DOH because through redesignation, there was concentration on the plan of care issue. So we didn't take that battle up on that discussion, but that was our stance. But you're already attesting that as you're attesting for billing, you're attesting that the individual you're billing for each month has Medicaid before you hit that submission button. So that's the stance that we're taking. You're already showing through that documentation that you're submitting that the person has Medicaid, you're validating that.
So is there any additional action that we need to take if that's the stance AHI is taking?
At this point, we're not saying that you have to, unless you wanted to do a case note. And I'm not saying you need to do that. I don't think you need to do anything else at this point, no. We're just bringing up that this was brought up on the EOP. I don't think you need to do anything else at this point, no.
Okay, thank you.
All right, anything else on this one? This is the informed consent policy. Ensure their case notes documenting that the health home's FAQ and consent forms were reviewed by the member and or a parent, legal guardian, or legally authorized representative. This one, we do want to make sure that we're documenting the health home's FAQ and consent forms were reviewed by the legal guardian, parent, or authorized representative. We didn't hit the mark quite on this as a network. So please make sure you're documenting it. That is in policy. I don't know if there's any questions or comments on this one. Okay. This one was around children's court service and billing. This one, particular to assessments, ensuring a member's record contains documentation indicate that they received in-person contacts for each month based on their level of complexity. Again, this is a network we did pretty well overall, but we didn't quite hit the 90% marker that would have hit the threshold that we were required to. So we have to ensure there's documentation in the case record justifying why an in-person contact did not occur as well when that was the circumstance. So gotta make sure the number of in-person contacts for each month are met and documented. And then if they weren't, document why. Any questions on this particular one or comments? Right, and then the next section, these are the last couple of slides here are around the comp assessment. There was the number of different categories in the service chart areas for the comp. There were two areas in particular that we didn't hit the threshold for 90%. One was around ensuring it's clear what the care manager does when working with the enrolled member. And you can see in the subcategories, primary care, housing, utilities, transportation, financial entitlements, education, durable medical equipment, and personal safety and medication. So there wasn't really a clear indication of what the care manager was doing and working with that person in those particular areas when those areas were reviewed for those particular charts. So just making sure that when working with individuals, it's clear, and that would be working through documentation and notes and identifying the goals, developing a plan of care, just, what is the role that the care manager's going to have in those areas, which will be reviewed in a slide coming up as well. So that was one thing that came up through the comp assessment area. And then the next area was around documentation in the chart that indicates what was completing care coordination activities related to the completion of the goal itself that the care manager was going to partake in. And this was specific to housing, food, and employment preference, those particular three areas in the service chart component for the comp assessment. So I don't know if there was any questions or comments specific to the comp assessment area. That anybody had.
So essentially, you're saying that when we complete the assessment, we're carrying over into the POC what we're going to do around these identified areas?
Yes, you should be indicating what you'll be working to help support that individual, or what particular, how that's going to transfer into what type of goal that you're going to help support them in, or how you're going to help carry out through, their plan of care activity, how you're going to support them in that activity.
Okay, thanks.
Yep.
Hi, I just had a question as well. Are you also indicating or talking about that last section of the comp assessment where you kind of write that little narrative about what the person's priorities are and how the care manager is planning to assist? That very last section?
The goals and priorities.
Yes.
What the individual wants, what's their goal and priority.
Yes. Yep.
That's going to help to develop what their plan of care is going to be established off from what, yes. So when you start to work on their goal plan and their priorities, that there's going to be, what are you going to be doing as a care manager or care coordinator to help them as those methodologies start to break out. There will be a component, it's their plan, but there's going to be certain parts along the way that you're going to be assisting them in that plan, right? So
Yeah.
you're not going to be doing it for them necessarily, but there'll be levels of assistance in there where you're going to be supporting them in certain areas.
Okay, making sure that's documented there. Okay, thank you.
Yep. Any other questions, comments? Right, so those were the main redesignation topics for this month that we were touching on. Jessica was going to go over quality assurance performance improvement compliance policy update for this year. So Jess, I was going to turn it over to you.
Hello, can you guys hear me?
We can hear
Yes.
you.
Yes.
Yeah, okay. Yeah, so we have a new policy that came out effective February of 2024. It came out after our February office hours, however, so we did not review it in February, so we're reviewing it this month. It was an annual review to our quality policy. However, we did add some updated language, and we also made a few edits. We added language in the policy around utilizing the NetSmart work lists. You guys do utilize the work lists now when you guys look at your gaps in care. We are going to be expanding the work list that we have. There are going to include other things. It's going to be something that is going to be front facing in NetSmart for the care managers. So if your care managers aren't logging into DataDen every single day, they are going to be able to have alerts right on their home screen. So we are working through that with NetSmart, hopefully to start getting some of those deployed soon. I have tested them in UAT, so we do have to hope to have those deployed and show those to you on a future office hours, but we wanted to get that language in the policy, letting you guys know that you do have that tool available to you. The other thing that we did is focusing on gaps in care. We continue to strengthen our approach with gaps in care. So we finally got those triggers imported into NetSmart. Now we really want to tighten up the timeline around when we address those new gaps in care that import into NetSmart. Some of the care managers are doing a great job. They're getting in there, they're addressing them, they're either putting them in progress or there's notes related to those gaps in care. And we unfortunately do still see some gaps in care just sitting open unaddressed. Upwards of a year they've sat in there without any resolution. So we wanted to make sure that we put something in policy because we are putting it is in our audit now. That we want to see those gaps in care followed up within 90 days of them entering the system so we can tell when those are imported and then making sure that there's movement on them within 90 days of import. That can be that you move it to an in progress status or there is a contact note or a care manager note referencing that open gap in care. The other update that is coming is that, as you all know, we do annual comprehensive audits for everybody. Moving forward, so starting if you were audited in February on, if you have an annual comprehensive audit score that meets or exceeds a 95%, you for that year will not be audited. You will still have your one-on-one meeting that we have with you. Just to touch base, it's your one-on-one time. It's the one time of year that we really get together. So we want to make sure we still do that. But if you are meeting or exceeding that 95% on your audit score, you will not have a full comprehensive audit. So in 2025, if you received a 95% or higher, you will not have an audit in 2026, but you will be audited in 2027. And that goes for each individual population. So if you are a CMA that serves adults and children, if you, let's say, scored 95 or above on your adults, but not for your kids, then we will just audit your children's population. One thing to keep in mind that when we do review those annual comprehensive audits, that you do get that audit reconciliation form. So that's for you to complete and fill out and send back to the health home. That's when you go through your audits and you say, hey, I was scored, I got a no on this, and it really is a yes because this is in there. You would send it all that information back on your reconciliation form. Those should go back to the health home. You can include Travis in on those and Kim. Please give us 72 hours, however, to review those forms prior to the meeting. This way, when we have the meeting, we can say, oh, we updated this person's score, we gave you credit back, or this is where we did not give you credit back. So those go hand in hand together with those annual comprehensive audits. And lastly, don't forget, now that quality notebooks are back out and running, to please make sure that those are returned to the lead health home. We did add language in there clarifying that those do need to be sent back. Again, you're going to send them back to the health home email. Feel free to CC Travis and Kim on those when you return them. And those are the updates to our quality policy. Does anybody have any questions about the policy in general or any of the updates? Alrighty. So Travis spoke to this a little bit earlier about when we have something that comes from the comprehensive assessment that is identified as a need, making sure that we have that in our plans of care. So this is one of the things that relates back to redesignation. And this is something that they found on our adult redesignation we had a few years ago, and most recently our children's redesignation, and something that we see when we audit records. So we really want to make sure that whenever we are looking at an assessment that we're completing, so whether that's the comprehensive assessment, the CANS assessment / comprehensive assessment, your safety and crisis plan for kiddos, anytime you see that there is a need, either for an initial assessment or on an annual assessment, you want to make sure that that is addressed in that plan of care. So you're going to identify that there is a need happening. So you want to make sure that you're developing an objective and intervention to address that need. So auditors such as us and or DOH, they will see, did this care manager identify that there was a need in one of these assessments? Did they add it to the plan of care in the form of objective or intervention, objective and intervention, depending on what the need is? And then what did they do? So that's kind of the next step. The first step is to identify the need, incorporate it into your plan of care. And the second step is to be able to read through your care manager notes and see what the care manager did to address those things. So you want to make sure it's two parts, that we're incorporating it into the plan of care, and then there is action on that item. As we're audited by the Department of Health, they have this grid that goes through kind of each section of need in our comprehensive assessment. They write down what the need is. Was it incorporated in the plan of care? And then what did the care manager do to address it? So putting something in your plan of care and then never addressing it through a care manager note, they would see that as deficient. Members, as we know, this is a person-centered plan of care. So if there is a need and they do not wish to address it, as long as it does not relate to their what makes them eligible and appropriate for health home, then they are allowed to say that they don't want to work on that. You just want to make sure that there's a correlating note that coincides with whatever assessment it is, that won't be addressed. So as long as there's clarification, something that we see a lot as an example of this would be like tobacco use, or someone who does have some sort of substance use. It's not what's making them eligible and appropriate, but it's something that they don't want to address. They don't want it on their plan of care. As long as there is a note addressing that, that is sufficient, and you will not be penalized for not having that on your plan of care. Does anyone have any questions surrounding this topic? All right.
Thank you, Jessica. The plan of care audit. So we are in process of meeting with the downstream providers now, and going through the audit results and talking through each organization and their particular results. We're sharing the audit tool with the organization after the results have been discussed. We are giving a 2-week time frame for the organization from the date of the audit meeting to do a internal review of the audit, to review AHI's audit, to go back, go through the audit, etc., provide feedback on our audit. As we go through that meeting with the organization, we talk about the self-disclosure process that we've been talking about all along over the last handful of months that the Department of Health has talked to us about in regards to potential takebacks that might have to come out of this process due to compliance concerns that may be identified. And then as a result of the internal review that the organization does based on the audit that AHI conducted, we'll take those results, we'll review what we get back for feedback, and then we'll go from there. And then we'll have to start making determinations on next steps. But we do have a timeline as we're meeting with the organizations that we've established based on our redesignation access points that we have through the Department of Health that we've established through June 30th, which we've shared with this group over office hours over time. But that's where we're at this point. We're in process of meeting with the organizations. And we're looking to wrap that up over the next couple of weeks and go into the next step of the process. So I just wanted to stop and if anybody had any questions or anything around where we're at with this, but that's what we're doing currently.
Hi, Travis. Is there any wiggle room with that 2 week getting back to you? Because there's school vacation coming up, so we have a lot of people out of the office the first week of, or starting after the 5th of April.
Yeah, I think if based on when the organization's meeting is and what the circumstances are, I think we can definitely talk with the organization in that situation for sure. You know, every organization's depending on when their meeting is and what their circumstances are is different. So it's open for discussion, but the 2 weeks is a timeline that we're looking to try to hold to as much as possible because of the time constraints that we're operating under. But yes, there is a potential for wiggle room.
Thank you.
Yes. Any other questions? All right. Oh, Andrea had one. Yes, Andrea.
Yes, I have a quick question. Based on what you guys are seeing, should agencies be preparing for funds to be given back, or can you talk a little bit more about what you're finding?
I can say that there are going to be take back scenarios across the region. There are themes that are coming up through this audit where there's plans of care missing. There are themes throughout the network where there's plans of care that have not been uploaded into the records for a number of months well after the fact of when they were due and should have been uploaded into the record, which is creating a billing issue. And that's a significant theme that's impacted across the network. I can say that the lead has really looked at that within the 56-day window. We're not looking to, you know, we're working with our attorney and we're not looking to try and incorporate any factors or billing instances or takebacks around that within the 56 days because that we believe shouldn't be an issue or should occur. So we haven't factored that into our audit. That's something that we're as a lead and as an organization prepared to, you know, defend against and plan on trying to defend against as we move forward. So we won't be factoring that in as we meet with organizations. It would be anything that would be past 56 days, plans that are not in the record at all, plans that don't have signatures, those instances.
And this is going back to 2023, correct?
Correct.
Okay, so it's safe to say that agencies should prepare for some sort of, you know, quote unquote take back, because I mean.
Well, I can say there's organizations that we've through our audit process that we've had a handful of organizations that don't have any issues at all for whatever
Oh,
that's
okay.
worth.
Okay, good to hear. Thank you.
Yes. But then there's organizations that have some themes, right? So we have a situation where we've got to work through this and as a network we have to make some corrections. Theme wise, Jessica, is there anything else theme wise I didn't mention? I mean, I'll be getting into specifics with each organization when I meet with the organizations, but But as far as themes, anything else, Jess?
Yeah, so when Travis does your meetings, he can absolutely get into specifics. But themes really varied agency to agency. We've have some CMAs that really have, I think, two CMAs that we've audited exclusively use that electronic signature function. So they were obviously not really easy to look at. There's nothing there. Everything checked out. The person did electronically sign. We did see some themes at other CMAs where most of the care managers were in compliance, but there were one or two care managers that were wildly out of compliance with signatures that really led to some findings. Other CMAs really had a smattering of issues where the plan of care signature was egregiously late or just not collected at all. So it's kind of agency dependent, but those are some of the things that we do see.
Yeah. Again, the details will be on the audit report for each organization to clearly have the ability to look at and go through and have a chance to thoroughly vet, basically. That's where we want to have an opportunity for the organization to do that. But anything else as far as questions?
Did AHI also look at whether we billed for certain months or not as well? So like if I had a late signed care plan or care plan not signed, but I didn't bill, will that also be indicated?
We looked at months billed for the time frame that plans were missing or out of compliance, not for months that they weren't billed.
Okay, thank you.
Yes. Someone else got their hand up? Charles?
Hey, just a quick question, Travis. We are fortunate enough to be able to do almost everything electronic, but I was just curious, starting last month, we still need to upload the care plan into the documents. Is that correct? Even if we're getting the electronic one in NetSmart?
No, if you're doing everything electronic, you don't have to do an upload. No, that's just that's just if you're doing the manual. The new process would be for manual uploads.
Oh, okay.
If you're doing everything electronic still, you're good to go.
Okay, perfect. Thank you.
Yep. Any other questions? Okay. Thank you, Jessica, for putting some comments on the themes as well. The next thing we had sent out to the network was a comp assessment required billing element. So we've been talking over time. We haven't mentioned it in office hours in a bit, but we're going through an OMIG audit. We've been in the audit since October of 23. Other health homes across the state are going through an audit as well through OMIG. We've been reaching out to organizations in the network throughout this audit that have had claims tied to the audit as needed. The audit's still going. It's been a year, over a year and a half, 2.5 years now, 2.5 years. And we're still not through the phase yet of it being complete. And one of the things that came back when we had an in-person meeting with OMIG in January was they presented a finding that they said that the comprehensive assessment, they felt it was a required billing element. And we did not agree with that statement. So we went to the Department of Health and was questioning that. And it took the Department of Health about a month to get back to us. And when they did, they had came back with the response that they were in alignment with OMIG's stance. And they referenced the CMS SPA indicating that the comprehensive assessment was a standard that was in alignment through CMS to help to build the plan of care. It was a required element to build a plan of care. Therefore, it was necessary and a required element of billing. But there was no policy that defined it was a billing element, and there's not a billing block in place. But they basically said you need to have a comprehensive assessment policy, which we do, and we always have. But they basically said if you don't have a comp in place and finalized, you can't or nor should you be billing for service for an individual. So at that point, we wanted to proactively reach out to the network. That's why we sent out the note that we did to basically reiterate what we've always done, make sure that you have a comp finalized and in place, so that you can ensure that you're in a good place for billing. And just to note that even though there's not a billing block, that DOH doesn't have a billing block out there. We want to make sure that people realize that DOH does take this stance. And we don't want down the road, if they ever do come back and do have a billing block or put something in place, to be caught off guard. Because a comp should be in place anyways when a plan of care is initially put in place and finalized. Annually, a comp's got to be in place when the annual plan of care has got to be updated. So it should always be there and should be finalized and be in place anyways. So that was the intent of this message. But the idea that it's a required element of billing was new news. And is not anything that we can find in a regulation anywhere. And, but we want to be proactive in messaging and just get that out to folks. So that we'll pause and if anybody's got any questions or comments, but that was the intent of this message. Charles, do you still have your hand up, or is that from before? Might be from before. Any questions on this in particular? Andrea?
I'm sorry, I might be confused. So it's a required element of billing, but it is not a billing block.
There's not a billing block in place, correct? But DOH is indicating that they're in alignment with OMIG stance, saying that it is a required element in order to bill. Yes.
So if, and again, I apologize, but if the comp assessment is not completed, like let's say it's a reassessment, it is late, and we submit our HML, is that funds we are going to receive, or we will not receive?
Based on the communication that we received, that should be completed and finalized in alignment with when the plan of care is due and the due date of the plan of care. So it should all be in sync and finalized in that timeline. So if it's done past the due date of the plan of care due date, then you would be out of alignment. So then you would be past the ability to bill. So it would be out of sync at that point.
So would you recommend on the HML that we say no, that a billable service was not provided?
I wouldn't recommend it at this point unless you have the comp done in time, based on this feedback that we got back from DOH.
Okay, thank you.
Trouble is there's not a billing block in place, and there's not anything that Department of Health or MAP, nothing's in place to prevent billing from going through.
He acknowledged
policy.
But
Go ahead. Was it Charles? Were you gonna say something? Anybody else have anything on this? Just trying to be proactive on this one, folks. This came out. We want to catch it in a way that's not going to come back down the road and have the Department of Health start to say, oh, you know, that there's a compliance issue because suddenly now they're looking at it differently, whereas they haven't in the past had it as a required element of billing, but now they're indicating they're in alignment with OMIG on it.
Hey, Travis, this is Marcus. Just a quick question.
Yes.
So we're doing our, at our initial enrollments, we're doing the PHQ-9 and comp assessment at that time. So should we be doing the plan of care at that time too?
No, you've got your 56 days to complete. Yeah, you have your timeline. I just want to complete the comp after the plan of care is due.
I got you.
Any other questions? Okay, manual plan of care signature procedure. Just want to remind everybody, got this up and running. One of the things I wanted to just note to folks on this, there have been some individuals out there that are uploading the plans of care into the document section. They're not going through the plan of care tab. You got to go through the care manager tab within NetSmart, not the documents section. So please make sure that you're going through the care manager tab to start the attachment process so that you can follow the new process. Because we've had a number of instances where folks are going through the documents as an attachment, and that's creating an issue. And we want to make sure that people are getting the proper alignment, getting the attachment in, using the new attachment function, as you can see in this slide, in the care manager plan tab. And then the date completed is going to be the signature date that the individual signed the plan. And that'll be the date that goes in and finalizes and attaches. And as everybody knows, or should know, February 18th was the date that went into play. And please let us know if there's issues or people are running into problems with the process. So we've been communicating with NetSmart. So we want to make sure we're working out any problems on this process to make sure that it's working the way it's supposed to, or if there's any unusual circumstance or things that weren't thought of, that we're addressing them as well. And one other thing I wanted to note as well, before this process started, plans of care and the old way of doing things, please make sure, because as we've been doing chart audits recently, we've come across some organizations that have not updated and uploaded their manual plans of care. So there's still, even though we started this process last November, December, January, before the new process started, we're encouraging and telling people, you got to get the plans of care in, you've got to get them signed. They're still missing plans of care, manual plans of care and charts. That's a billing concern for folks if they're not in there. So please encourage people to check your charts, make sure you got your plans of care in there. People get their plans of care uploaded. so you don't get in a compromised circumstance for billing. Can't stress that enough.
But while we're working on that, it's okay if we're marking the HML as not billable, correct?
If you're marking it as not billable, you're gonna be all right, but if you're marking it as billable, if it's marked as billable and you've got no plan of care in there, or that's gonna create an issue where we're gonna have a billing concern. That's gonna be a take back or a void for sure. General updates, reminders, just professional network. I know Jessica's brought this up over the last handful of office hours. It's gonna go live in June with the map update. So just as you're in there in that care coordination tab, you just gotta have at least one person listed in their professional network. And if folks have been doing that, we really appreciate it. If you haven't gotten in there yet, please make sure that you're trying to get in and getting those things going. Karen or Corinne, I'm sorry. Yes. Corinne? Can't hear her.
No, she said her mic, can you hear me?
Yes.
Okay, said her mic is not working. If it's the same, she put a question in the chat. It says the tab was there a couple weeks ago. The new attachment tab is no longer there. We have not heard that from anybody. If you could please send us the chart ID that you were in an email and we can follow up.
Yes, thanks for telling us. I didn't know that either. Anybody else have anything on that one? That's. And then the HCBS internal audit we had to do has been completed. Jess, did you have anything you wanted to add on that? It was submitted.
Yes, so everybody who had an active member who was in HCBS from January 1st onward was audited. It was about 11 records, 9 unique members. The results were sent out for those, and corrective action plans, if applicable, were sent on the 13th. I will follow up on those on the 15th of May for a re-audit depending on your active caseload. And then everything was sent to the Department of Health yesterday. So just waiting to hear back from them if they have any feedback on our self-audit.
Thank you. And that was what we had for this month. Did anybody have anything else they wanted to talk about or mention? All right. Well, thank you all for everything you do. And I hope you have a good rest of your day. Thanks for everything. Talk with you soon. Thank you.